Thank you very much. Good afternoon, everyone. Thanks for the kind introduction, and thank you to the organizing committee for inviting me. Thanks, Animesh. So it's kind of a challenging topic when I was thinking about how to cover all this in 20 minutes. And a lot of gray areas, as you already know, about stage 3 disease and its management. So I'll try to cover the evidence base and see how we get along. It's a quick outline of the talk. I've taken the liberty of actually talking a little bit about the operable disease as well. I think it's slightly difficult and to cover just the unresectable disease on its own, given the gray area between the resectable and non-resectable disease. And also in context of when clinical practice, it's probably better just to have a little bit of overview of both these diseases alongside each other. So the main focus will still be unresectable locally advanced cancer, but I'll talk a little bit about resectability of the tumor. We'll go through evidence base in both these settings, and in the end, I will talk a little bit about dose escalation. So just to give you a visual presentation of what is stage 3 disease, or where we kind of draw a line for locally advanced lung cancer. A lot of discussion in MDTs with our surgical colleagues, what is resectable and what's not. And I think this debate will probably continue a little longer till we get a more clear guidelines and consensus way to draw the line. So this looks like a single node, mediastinal node stage 3 disease. You'll argue whether you should do surgery or radiotherapy. You know, when I make it node a little bit more bigger, again, how the discussion will go, I'll leave this to you guys, but just put this same disease in context of more nodal burden. Again, I'm sure discussion will happen in the MDT and we will have opinions. You may have a tumor with central necrosis that will change the discussion and approach. You may have a large tumor with more widespread nodal disease. This gives you how much heterogeneous this group is. You may have SCF nodes, but the tumor is lying close to it. You may want to include all that in the chemoradiation setting, or you may have a tumor which is lying far away from the nodal volume. So as I said, it's quite difficult to kind of come up with a straightforward presentation of what we need to do for this patient group. But we'll try to simplify it. And we all know that when we talk about N2, N3 disease, or mainly stage 4 disease, you will be most often thinking about non-surgical treatment. And that's what we will mainly discuss today. Multiple ways to treat this, as we talked about, as mentioned by my colleague earlier. Radical chemoradiotherapy is standard approach. Obviously, we know from Pacific trial, most patients, if suitable, will have Durva, otherwise just radical chemoradiotherapy option. You've got sequential chemoradiotherapy, you've got radiotherapy alone, different fractionation options, you've got chart approach, and now we have option of TKIs, not only osimertinib, we've recently had data for our ALK patients as well in adjuvant setting. So let's look at the evidence base, a little bit flavor in the operable setting. We all know an Albion study, which looked at chemoradiotherapy followed by surgery versus chemoradiotherapy. No real improvement in overall survival. In fact, patients who underwent pneumonectomy unfortunately did worse. What does NICE say and how our practice is in UK? If you look at the NICE guidelines, it talks about chemoradiotherapy before surgery. But in reality, do we do that? Not really. Most of patients will have neoadjuvant chemo, proceed to surgery. It's rare for us to do induction chemoradiotherapy unless we are going for a pan-cause tumor approach. Few studies are looking into the role of chemoradiotherapy with immunotherapy in operable non-small cell setting. I've summarized these before here. I wouldn't go into details, but we'll have to kind of look at it as, could the immunotherapy in combination with chemo or radiotherapy be a standard of care in future? I think that's the question. Hopefully, we'll have answer to in coming years. But it's getting interesting, and I'm sure there will be role of these approaches going forward. Now, coming to what we do with patients who are upfront considered not for surgery. Historically, we've done sequential or concurrent chemorad. At present, we are doing concurrent chemorad followed by immunotherapy, pretty standard approach. So what's the future and how we can improve that? IO sequencing with immunotherapy, or additional treatments that we can consider along with these. Just a bit of flavor of past. We are well aware of appearance study, which showed that sequential chemoradiotherapy was inferior to concurrent, pretty standard practice now. We had dose escalation study, our TOG 061 study. I will talk about a little bit more about this in detail later on, especially the revised version. Didn't do really well with dose escalation, and we'll look into potential factors why it didn't and what needs to be done to get better outcomes with dose escalation. Proclaim study looked at combining different chemotherapy regimes. Again, no real benefit that we saw. We know the hypofractionated regimes have been trialed. This trial specifically looked at daily cisplatin at low dose with hypofractionated radiotherapy. Decent outcomes, didn't really change our practice. And we had hyperfractionated radiotherapy, the INDAR study, which was a phase 2 trial, which looked at 1 cycle of induction chemo followed by 2 cycles concurrently, and patient had 1.5 gray BD dose to 45 gray, and then it was later on escalated at 2 gray per fraction, respecting the OAR tolerances. So what's the summary of all this? Didn't really get better overall survival outcomes with conventional versus the other fractionated radiotherapy. So no real change in terms of outcomes by these approaches. And then we had the practice changing study with the Pacific trial. I think we all are well aware of this now, discussed multiple times in different meetings. We have patients who upfront are not resectable. They receive concurrent chemoradiotherapy, and they were given durva versus placebo. I think the one important thing which we have to mention here is that though it's a fantastic treatment approach, I think it can be difficult for patients. So especially when you're looking at patients who are recovering from chemoradiotherapy treatment and to go on durva, this has to be a very good selection of patients there. They have to recover well. They should not have any grade 2 or above toxicity, which makes you a bit of a worry putting them on immunotherapy. So it's not as straightforward as thing in real life, but yes, patients are doing quite well who end up completing durva, and this showed really good outcomes in terms of improved overall survival and PFS. So standard practice, we all agree this is a better treatment. Let's look into a little bit more detail of what happened with the subset of patients who actually have EGFR mutation. And we know there was a small number in this trial which actually received adjuvant immunotherapy while they were EGFR positive. And we all have our doubts about the role of immunotherapy in these group of patients. And then we have PD-L1 patients with subset who had higher expression as compared to no expression. There is clear difference in patients with high PD-L1 actually do better. We don't really know about the patient group who have EGFR mutation. When you look at the curve specifically to these patients who received durva in this trial with EGFR positive mutation, no real improvement seen in both PFS or overall survival. We just have to look at a little bit at this with a little bit of caution because it was a small patient group. We already know these patients don't do very well in other settings, especially in metastatic setting. But we now have good evidence from LAURA study that actually osimertinib is a better treatment strategy in these patients rather than considering IO. But I think our IO question is still unanswered, but it's not very optimistic as much as we can tell at the moment. So what's the future? How we can improve the outcomes further after the Pacific trial? The few studies that are ongoing, I'll just briefly touch on them and then give you a little bit of flavor what is likely to come in near future. So ETOP 614 Nicholas trial. So this is it had 79 patients recruited. So this data is a little bit old. I didn't update the slide, but the final data is not out yet. So what they're trying to do is they're combining chemoimmunotherapy with radiotherapy. And in one arm, they are giving 1 cycle of chemo up front, and then chemoradio and IO are then combined. In group 2, they're completing the chemotherapy first, and then radiotherapy and immunotherapy are started together. So it's slightly different approaches. So majority of these patients are stage 3B disease, and that's where we want more high-risk patients, how they will do. So good high risk population in the good number of high risk population in this trial. So the first year PFS was promising. A median overall survival of 38 months, 2-year overall survival of 63%. So hopefully the final results will give us a better idea. Toxicity profile, a little bit more toxicity when they were combining the 3 modalities, which is expected, but I think it was tolerable. There were 5 grade 5 toxicity more in the arm which combined the 3 modalities. So we need a little bit more data in terms of outcomes before we can draw a conclusion. Then we've got Keynote 799 study, which actually is looking at combining pembro with chemotherapy with either carbopacly for both squamous and non-squamous, or cispem in non-squamous. And these patients are then receiving radiotherapy along with chemoimmunotherapy, followed by IO in adjuvant setting. So kind of a quite intense treatment regime. Again, this is the group of patients who are unresectable, majority stage 3A to C, and a good performance status. So the initial results, there was no real difference in our overall response rate outcomes, but a little bit concerned about grade 3 pneumonitis, around 8% of the patients in cohort A and around 7% B. But when you look at the same in comparison to Pacific study, the pneumonitis risk was lower, any significant toxicity. That kind of makes sense as well when you are combining these modalities together and then having in adjuvant setting as well. But these are the things to look forward to. Then we've got Keylink 12 study, which has got 3 arms, and it actually is looking at olaparib versus placebo versus durva after concurrent chemoradiotherapy, and there is obviously immunotherapy combination to start with. I think one thing we could say is that there's more and more data coming through about safety of combining immunotherapy with chemoradiotherapy, which is quite concern when you think about our clinical practice and the toxicity risk that patients could potentially have. So I think the safety data will be quite encouraging, and then obviously thinking about the better outcomes going forward. This is another study which has got slightly different approach, where they are looking at concurrent chemoradiotherapy, followed by response assessment, and then depending upon their response, then further offering these patients immunotherapy with nivolumab with different dose strategies. So that's another very interesting approach, where not only you are trying to divide patients based on their stage as well as histology, but also looking at their initial response and different dose of immunotherapy. The initial results, again, immunotherapy, which was offered in combination with ipi-nivo, had slightly more toxicity, but pretty similar to what the data we have got in ipi-nivo in metastatic setting. Obviously, it was a little bit lower in nivo alone. Just to summarize the trials of this study, that after 18 months, the PFS improved to 18 months, which was better. Overall survival was quite comparable to the prior consolidation trials. The toxicity was again similar. As I discussed, it was a little bit more in ipi-nivo arm. But this trial is looking at actually the accelerated radiotherapy versus conventional radiotherapy, and the feasibility was defined as at least 80% of the patient in each arm to receive 80% of the planned dose of durva. And here what they did in 2 cohorts, that they offered durva with RT, obviously with different regimes. I wouldn't go into details of that, but just to give you a flavor that the results, flavor of results, that the primary objective of the study was met, but the secondary objective was not met. So there will be challenges in doing these trials, but there's a lot of work going on, and kind of gives you a bit of reassurance that this is possibly doable. You would hope the results to be better, but we just have to wait for the data for these trials to mature. Then moving forward to this sprint study, this is kind of an approach where they used immunotherapy in what we call not peri-RT setting, how to call it like we say in peri-operative setting, without chemotherapy, and see how we do without chemo, but just go for IO and radiotherapy. So median follow-up of 13 months and overall survival at 1 year, 95%. There was no grade 4-5 toxicity, which is quite reassuring. There were grade 3 toxicity cases, which I think you would expect to see. But one important thing was in this trial was this was PET-based dose painted. I'll come to that. So the dose escalation in the study is important and encouraging. It's probably why we got better toxicity profile and hopefully better outcomes. But still, a little bit of way to get more answers to this. We all know about the Pacific data and how well it did in terms of improving outcome, but there was the Pacific 2 study which combined durva in concurrent setting and actually didn't show any benefit. So, there are some signals that this approach may not improve the outcomes, but I think it's worth waiting for all the data to come. Then looking at immunotherapy in stage 1 and 2 study setting, and this is a study which looked at combining immunotherapy with SABR, and quite decent follow-up with the primary endpoint was at 4-year event-free survival, and there was very good separation of curves that actually combining immunotherapy with SABR did better. Again, it's important to ensure the safety in these patients, and we have to do these trials in a very, very well-controlled environment. But just gives you an idea that it is doable, and there was no real toxicity concerns. Slightly different approach with looking at different targeted therapies with radiotherapy, especially the DNA damage inhibitors. And we've got Concord study, which is still recruiting patients in UK, and it's got multiple arms and multiple drugs that we are looking into, and Reparib, there is other drugs and also immunotherapy arms. So it will be interesting to see how the results of this. This is purely RT alone study and not concurrent chemo-rad. I'll go into details of that in the interest of time. So what is beyond concurrent chemo-rad or 60 gray? We know local control still remains a problem with high failure rates at 3 and 5 years. There is data to support historically that dose escalation is a reasonable strategy that we need to look more into detail with. And we know that if we increase the BED, more you increase, the likely that it should improve the outcomes in the long term. And there are phase 1-2 studies of concurrent chemo-rad that looked at 74 gray with some promising outcomes. So just coming back to our TOG 061 study, and there was this revised version where we looked at concurrent chemo-rad with carbopectly, and there was it was 60 versus 74 gray, 2 grip of fraction, and also looked at cetuximab, and we know that it didn't give us the results that we were hoping for. Possible reasons you can think about, longer treatment time resulting in accelerated repopulation, higher dose to normal tissue causing more toxicity. I'll talk a little bit more in detail about it. We know esophagitis and heart rate dose showed that it actually impacted on survival, and it was quite detrimental if the doses were higher. This is quite a beautiful slide, which I really like. Thanks to Prof. Ferry for sharing this with us. And it actually showed that the part V5 and V30 higher doses actually increased the risk of death, and also the effect on the immune system by the radiotherapy with more grade 3 leukopenia had worse outcomes. And you can look into the substructure data as well. And if you are giving higher doses, unfortunately, it was resulting in poor outcomes. Still, I think we need more evidence base for it, but there's now evidence talking about looking at contouring the heart as a substructures and trying to quantify the dose to substructures rather than what our usual approach is. Then coming to dose escalation, there are quite a few studies, and I can't cover all of them in the interest of time, but there's this summary of this. And essentially, these are PET-based strategies where we adapt our radiotherapy approach in terms of planning and delivery. And I'll just skip these, but essentially a lot of work that's been done at the moment with looking at different dose escalation strategies, combining with different sensitizers and see if we can get the better results. It obviously does need better setup, better imaging, and PET has been used in terms of using it upfront in simulation and then also at contouring. And just coming to just give you a little bit of visual presentation of this, that we can either take an approach where we do anatomical adaptive radiotherapy or biological adaptive radiotherapy, and I'll come to that a little bit more in detail. But it does give you a little bit of idea that if you can have a better way of targeting the tumor with better dose distribution, respecting your OAR, the higher the dose you get to the tumor, hopefully you should get better results. And based on that principle, we have now got strategies where you can have dose painting by contours versus dose painting by numbers. And essentially, I won't make it technical and boring, but essentially what you're trying to do is that you can either make up a high dose CTV like we boost a GTV. We define that based on PET, the area which has got SUV of like more than 50%. If we define that, we boost the whole area. So that is how you escalate the dose based on contours. Or you can just go by the variation in SUV and increase the dose as the SUV is increasing. So taking like a linear approach, which will obviously divide your target volume into small subsets. And the smaller the subset, the higher the dose escalation is possible, because hopefully you will be able to stay away from OAR constraints, which is the main limiting factor. And this is how, if you look at those two strategies, you can actually have a little bit of an idea about how the dose will come at the end in terms of distribution by taking these two slightly different approaches. I think the OAR, respecting the OARs and trying to learn more about the constraints is still very important. And cardiac sparing, I know there's a lot of literature that's been published. I'm sure you all are well aware of that. I've just put some trials which have looked at trying to redefine this for us. I won't go into details of that. Also for reducing the risk of esophagitis, we know that both these were very detrimental in trial with higher doses resulting in worse outcomes. So I'm not sure I've helped you or I've confused you more, but I think it's good to think about these strategies and good to kind of look into improving the outcomes of our patients with different approaches. So just to summarize, where are we with operable disease? Still, it's considerable debate on what is operable. We know if the patient is planned for pneumonectomy, are we still as radiation oncologists comfortable with those approaches, or we have got a good alternative? Somebody's got PD-L1 positive, or maybe higher PD-L1 figure. Should that influence operability? I don't think we've got clear answers to that, but we've got Pioneer study which is actually looking into that, the strategy of non-surgical approach in patients with operable disease. And hopefully this will give us a little bit more insight to address these questions. Again, I talked about the current NICE guidelines. Talk about chemoradiotherapy before surgery, but that's not kind of a routine practice in UK unless it's a superior cell tumor. We talked about that in future is the role of induction chemo-RT in immunotherapy in operable disease, and where does this fit with induction chemo and immunotherapy? As a new standard in operable stage 3 treatment. We will see. In non-operable setting, we've got a pretty standard approach with with chemoradiotherapy followed by durva. Now we have EGFR, osimertinib, or ALK-targeted therapies, but we still don't know where we fit immunotherapy in those patients. There's a lot of studies going on. Hopefully, we'll have more data and in coming to the dose escalation, I think uniform dose escalation is always tricky and has been difficult to do. And the new strategies, especially with dose painting strategies that we've talked about, give us a new hope for escalating this and hoping to get better outcomes and better training, better treatment delivery systems, and obviously personalized radiotherapy plans is the way forward. I want to thank Animesh for sharing some of his slides with me, which I've used today, and my colleague Dr. Franks. Thank you. I hope it was helpful. Please let me know if any questions.
Thank you, Dr. Tanzeel. Any questions from the floor or any interaction? He'll be glad to answer. Otherwise, thank you for the wonderful discussion, a detailed discussion. Thank you very much.